So as I see, three surgeons, a medical oncologist, a radiation oncologist, and we have a radiologist as well, right? Dr. Nivedita is there? Right. I think she's not there. Yeah, right, fine. I think all the speakers have really done a great job. So it was a great learning for me as well as we were going through the slides. So what I'll go through in this panel was, we'll just probably mull through some of these papers itself and try to sort of see how is our real world evidences based on that. How is our real world practices essentially based on that. Yeah. Say, maybe I would first start with Devani. What do we understand by early stage? Like, here most of it was around stage 1. And how do we sort of, define early stage, Dr. Devyani? Like, what is your understanding of early stage?
So I think the table that you put up is from the AJCC 8.
Right.
And anything that's T1, T2, N0 or N1,
right.
I think that would be the upper limit for early stage in.
Okay, fine, great. I think.
Having said that, I think the definitions differ across papers.
No, I just wanted to understand, like, is there any standard definition?
There isn't, but I think the consensus would be T1, T2, N0, N1.
Right. Okay. So just wanted to get that point across. And maybe for favor of the panel, I thought I'd just take this particular one case scenario. I'm not going too much details into this case. It's just a 75-year-old gentleman. CT1C, N0M0, yeah? It was, say, maybe a 2.5 centimeters, no nodes. And maybe I'll just directly tell, like, the management. Shoaib, Dr. Shoaib, you want to ask anything else? Or no, I thought, like, we'll...
What's the histology?
We're to work up. Yeah, assume it's an adenocarcinoma.
So if there are no nodes on PET?
Yeah, it's at 2.5 centimeters, PET staged. This is the lesion. T1C, N0M0. And management options. How do we sort of, maybe I will sort of, throw this as well, like, whether it's 75-year-old gentleman, SBRT, RFA, or this image-guided thermal ablations, is it surgery or neoadjuvant, I think.
We'll assess his fitness for the surgery, pulmonary function tests, and medical comorbidities.
Perfect.
And if patient is found suitable, then the surgery should be the first treatment of choice.
Perfect. Priya, how do we sort of go about this? Because this is a very important distinction. No? They say medical inoperable, medical operable. So I think that actually defines a lot of the choices of treatment. So how is the normal workup that you all tend to do at your center? Like,
so 75-year-old patient, smoker, non-smoker, the first thing, any comorbidities.
Right.
We would do, starting on the simple things, a 6-minute walk test, a room air ABG, a pulmonary function test, including a DLCO.
Right.
And echocardiography, and if he has plus minus any comorbidities, a dobutamine stress test too.
Right.
So once we are done with that, we plan for surgery. But for T1C, before we go on to surgery, I would also like an MRI brain.
Perfect. Devyani, anything like, do you stop at PFT DLCO, or do you do is it graded, or do you sort of directly do the 6-minute or dobutamine? How is it like in your practices?
So he's 75.
75, yep.
Like Priya said, assessing his fitness is going to be important.
Right.
The first thing is self-reported stair climbing, which is the simplest thing.
Right. That's what most of us do, no? Do mare chad sakte ho and all those things. I know that's what
that
more.
That would be the first go-to,
right.
And then I think the least technical would be the 6-minute walk test, which can easily be done in the first
so
visit.
in real world, how do you go about it?
So
I just wanted to
self-reported stair climbing, 6-minute walk test on the first visit if you think he's going to be a surgical candidate, and then the PFT DLCO. Having said that. In this guy, definitely PFT DLCO, smoker, definitely. But especially during COVID times, we kind of didn't do PFT DLCO for all the patients because it's an aerosol generating process. And we did it only for smokers or people with pre-existing lung conditions and in resections which were more than a lobectomy.
Right.
And we
so what is your definition of medically inoperable? if I were to sort of put you in a spot or something. No, I just want to get your, I think it may be different for different people. I think,
I would say where the risk of the treatment that you're going to give to the patient outweighs the benefit would be medically inoperable.
Any more objective criteria you could sort of, put it like, because the evidence says that, maybe SBRT you tend to favor, or any of the other techniques, RFA or IG, in medically inoperable. So how do we sort of do this distinction in the real world? Priya, you wanted to sort of add something.
I'm sure, we both would say the same thing. If you're asking for an objective criteria, it would be the FE1 and the DLCO levels.
Right.
So if they are less than 40, he's high risk, less than 30, he's very high risk, 75 with very poor high risk factor, I think we would just send him for SBR.
Question actually, do you use 40 in your practice now or 30?
30.
Yeah, okay. Sure, anything, how do we sort of, obviously, we go by the history, physical examination, all the other parameters and all those things, but how do we sort of, say like, we say no surgery for this patient? Like, when do we sort of, any pointers in real world? I think
Surgeons, very difficult to say no.
We rely more on the post-operative FEV1, which should not be less than 800 ml to 1 liter. Maybe for this gentleman, 1 liter should be the cutoff rather than 800 ml.
Just to put things in perspective, I think we have a lot of functional evaluation criteria, the ACCP criteria, ESTS criteria, and the European Respiratory Society. So you take one of the criteria and maybe try to sort of label. Amit, since you're there, like, I just wanted to understand, like, about image-guided thermal ablations, RFA, like, when do you sort of what is your experience and how do we sort of take it in your real world?
So basically, one thing is that it has to be non-negative and
correct. Say, assume this patient, like for all these purposes, let's sort of revolve our talk around this patient.
So if it is size is less than 3 centimeter, that is one. If it is peripherally located, not near to the hilum, because for vessels.
Now, considering this evidence also, like, where do you sort of place it? That really had a.
So I think.
So do we say that considering this evidence, almost twice the amount of local control, overall survival almost twice better with SBRT. So where do we actually place
so I think there is
RFA
one,
or any image?
So there is, I think, one more trial. There is a rupture trial
that
highlights that RFA has also equal good control as compared to the SBRT, and over like the 2 years follow-up interval and the 5-year overall survival are almost comparable. With that of the SBRT. I think that is not included probably.
Right. So do you say that there's still some sort of, it's not the end of the road for RFA or image guided, there's still some sort of role, say in the medically inoperable cohort?
Yeah, definitely.
Right. Okay, great. And anything other than RFA, would you have any experience? Like, I know there are 4 or 5 things, cryo, laser, microwave,
so cryo we don't do,
electroporation.
The most commonly used modality for lung ablation is the microwave ablation, which is
right.
better control as compared to the RFA.
Right. Dr. Jacob, you wanted to say something. Would you consider, say, any neoadjuvant approach for this particular patient, stage 1, C75?
So adjuvant treatment, it is beneficial even in elderly individuals in lung cancer. That's the veteran trials have shown that.
Right.
It's possibly because it comes back reasonably fast.
Right.
And neoadjuvant systemic therapies, particularly immunotherapy, I think, it is becoming standard now. Pathological response rates are more, eventually survival is likely to be more. Chemo alone may not work that well. The major problem technical in this patient will be to give chemo, not the immuno.
Right.
But giving only the immuno, it's not a way to go. You need the combo. So maybe can be tried. There's likely to be effect, and you probably give immunotherapy with some modified doses of chemotherapy.
Right. So maybe most of the evidences are slightly for higher stages, but I guess, with more evidence, I think it may come even for smaller tumors as well. So for SBRT, like, what is your take? Like, you were keenly following this discussion. I just wanted to have your take. Same patient, 75-year-old gentleman, say consider he's medically inoperable for one of the criteria, like, so.
Yeah, actually, current recommendation is if it's medically inoperable, then we go for SBRT. But there are, except for operable and inoperable, there is one gray zone where it is high risk operable.
Right,
So
right.
some European guidelines push that more than 75 years is considered in this physics.
Yeah,
So as a
absolutely.
radiation oncologist, 75 years, I may push for SBRT.
Right. Great. Any thoughts, Priya and Devyani? They have they say mentioned exactly about age criteria. Of course, though we know that age is sort of just a number of such. Great. So anyway, moving on. I think it's Amit. You did mention about some of the local recurrence. So I just wanted to understand, Amit, what is the follow-up of these patients like after SBRT? Maybe Amit can take it, and then Amit, how do you follow up these patients after any of these SBRT or image-guided ablations? So I think that's also an important challenge.
So if we do ablation, we will do a scan after 3 months to see whether there is any, how is the ablation has done it. And then subsequently at 6 months, then 1 year, and then after 2 years. So that is how the follow-up interval is decided.
So every 3 to 6 months, or how is it like?
So first it is every 3 months. Then after that there is a 6 month, and after that it is annual follow-up we will do for, and that is with the low dose CT.
So you showed us some elegant pictures and all those things. So how was do you still follow this criteria? You said that the criteria was very fluid to detect recurrences following SBRT. So
yeah. So the thing is that for SBRT, definitely the criteria is very fluid. For RFA, it is little bit better defined. But the thing is that we watch for the features which are high risk. Right. So that is the thing. We are not following the criteria for resist because that is not in particular applicable here in the post-RT scenario in the lung. So we have to watch for high risk features like whether there is any local air foci which is now coming with a solid nodule, or there is a convex bulging margins. There is a craniocaudal extent of the tumor that is increasing. So these are the features which will make a high risk, and it will help you to pick up recurrences at 3 or 6 month of an interval or residual disease.
So any sort of salvage following SBRT, any of you all have done it in your practices? Maybe Devyani, you can take a call on
so SBRT has become a very attractive
use the mic.
option. So we've been using it more else here.
Is there. So
we have salvaged a couple of cases till now.
Right.
And it's worked well so far, but it's not enough
numbers. No, how we just wanted to understand, because these are slightly newer things in real world, so we don't normally get all these things to salvage.
We don't normally get it either. They do fantastic job with it.
So oh great, I'm sure that they are, but I just wanted to understand how many cases would you have salvaged and what did you all get to do?
One, that's it.
Right. So when is your threshold to sort of, needle a lesion or something like that? Maybe within 1 year. I know after 1 year following this publication, I think people would sort of be hesitant to needle. Very often what happens is you have some sort of opacity, you don't really know, and you go back to your radiologist, go back and forth, not knowing when to needle or whether to needle.
Yeah, so we need the opinion of Dr. Amit Janu, as he has already said, that the radiologist opinion on the radiologic features of the post-SBRT, especially after 12 months, because it will be like a mass-like fibrosis. Right. It is very difficult, actually, as Amit has already mentioned, to differentiate between a mass-like fibrosis and the local recurrence.
Right.
As soon as they say that it is a suspicious lesion for local recurrence, we ask for a PET CT scan. And if it is also of a higher SUV than the previous or the baseline.
They mentioned some more than 5 mean increase in SUV, at least in this paper that they had mentioned.
And then only we take the opinion of our surgeon whether the patient is initially medically inoperable because of the high risk criteria, and now.
So, and very quickly, how many fractions in SBRT you do? 1 or 5? 5 fractions. So, any center in the world which is doing 1 fraction, I was actually
there was a randomized control trial called the RTOG 0915 that has seen the 34 gray in a single fraction versus 4 fraction. So the local control rate were more or less similar, and the progression-free survival was also more or less similar.
I was actually blown away by seeing the single fraction, so much, but I think that is something,
a small patient cohort, it should be peripheral less than 2 centimeters, just like 1B.
Right. Okay,
which
now
will not get in our country.
Right. Now, so enough about the medically inoperable. Let's come to the core of the discussion, and surgical considerations. And I think Prashant elegantly presented this paper. No, I just wanted to know maybe the surgeons more loco-regional recurrences in the segmentectomy, but yet better 5-year overall survival. Like, your take on this, maybe Shoaib, you can sort of, take on this. Since you also elegantly brought about the Noguchi criteria and all, so I think it's very, very highly selected cohort of patients that they actually took it in the trial. Like, so this is something that was slightly puzzling, essentially, but your thoughts on this, or any other thoughts on this paper apart from the criteria?
I do not know when more local recurrences
Yeah,
happen, then how can the survival
yeah. Priya, Devyani, any thoughts on this? Like,
I think the only way
increase
loco-regional recurrences with an increased survival would only happen in you need two things. You need to
Right.
pick them up in time, and you need an effective salvage, which the Japanese seem to have done really well.
Right.
But the increased loco-regional recurrence was actually not seen in the CalGB study, where 50% were actually just wedge resections.
That's surprising, no? So here you had a wonderful trial, as Prashant said. Every patient had a segmentectomy, clear margins, more than 2 centimeters. Still, I think the notable point was almost twice the number of local recurrences, yes. Yeah. No, interesting point in this trial from what I read was, I think there were more amount of non-cancer related deaths in this.
Which is also what explains.
Yeah. I think this is something that, they said we are not able to actually. So the cancer related deaths or lung cancer related deaths were actually possibly equal, but more amount of non-lung cancer related deaths were there in this paper. So do we sort of, change practices? Also, I think, Priya, you did present the other paper as well, like, about lobar versus sublobar. So I think the bottom line is anything more than stage 1B or stage 1B, that's for say 1B, it's a more than 3 centimeters. So whenever there's more than 3 centimeters, I think to get a 2 centimeter margin, all those things are going to be tough. So I think the standard is that you do a lobectomy whenever you have more than 3 centimeters around the threshold. Only thing is 1A, and maybe your numbers will be slightly lesser. And even this paper, so you have 2 papers now, even this meta-analysis also, and also this randomized control trial. Of course, it was very heavily selected. The other thing was that they did a mediastinal sort of lymph node dissection also. Any N1 node, if it was there, they would not do a segmentectomy. I think that was the important caveat of the trial. So they used to do a lobectomy for these patients as well. So it's a very, very selected subgroup of 1A. Yeah, yes, Vijay, I wanted to get you in. Yeah.
Osimertinib, or he receives immunotherapy, and the lesion initially was 4 centimeters because that's why he was given, and now the lesion is 2 centimeters. So do we follow that breast kind of strategy and now say that we would go do segmentectomy on sublobar resection, or we will still follow and do?
Devyani picked the mic, so I think, so.
I'll take that one.
Yeah.
So I think we're going to see this more and more as we give neoadjuvant therapy. But I still think that we need to plan our surgery depending on the pre-chemo or the pre-IO imaging, because the whole mandate depends on whether your primary has thrown nodal mets or not. So that's what decides the extent of surgery.
Yeah.
So I don't think
Yeah, Priya, you want to?
So I guess for that particular reason itself, that's what they did. They did a they did the frozen section and they checked out. If it was N1, they went on to do a lobectomy.
Correct.
So the deduction size will not be as significantly important as a nodal met would be. So if it's N1, patient would still go ahead with a lobectomy as per that
point.
trial.
But Vijay had different point. Yeah, Shoaib, you wanted to add something.
I think in our scenario, in Indian settings, we should avoid sublobar resections. Because, Japanese, the commonest procedure done there is the segmentectomy.
Right.
When I was there, in first month, I hardly saw 1 or 2 lobectomies, always segmentectomy.
Right.
And they had very strict criteria to do segmentectomy. Like Noguchi, I do not know whether they followed this in this or not. And they used to say that they used to do segmentectomy only for Noguchi's A, where there was only a lipidic pattern plus some microinvasion without any fibroblastic proliferation. And they said survival for such patients is 100%. 5-year survival.
Yeah.
So I think...
maybe we will not say not do, but we'll say that we highly selected. The numbers may be less, but whenever you're getting possibly a patient who's fitting into the 1A criteria with the peripheral, and you're getting able to get the margins and that. But interesting, I think, point Vijay brought out, because in many other cancers, the same thing comes, in breast, in head and neck. What are the margins? Again, I think that same thing, because of the neoadjuvant treatments, everything is slowly coming into the lung cancers. Well, Priya, you wanted to make a point?
Same, similar.
Right. Fine, great. So I think that's a message. I think 1A, maybe selected patients you do. 1B, I think preferably do a lobectomy. And of course, Sarvana did present about VATS, RATs, and he very elegantly he summed it up. Anything more you wanted to add on this, Shoaib, or anybody else? I think for now, I think it seems pretty much same. Okay. If there's anything more you wanted to add, or we'll just go to probably the next paper of Durgatosh's thing of vascular invasion. I think this was something very, very interesting. How many of you all sort of ask your pathologist to sort of look into this aspect?
I think all would, and especially
so is it a component? I think it's a regular component of a synoptic reporting in lung cancer. And maybe let me come straight to the point. So maybe stage 1A angioinvasive. I think would you be compelled to sort of give adjuvant chemotherapy, or adjuvant therapy, and that's what I think. More than some 50 publications are there saying that angioinvasion is a poor prognostic factor and all those things. So how will be the thought process following this sort of meta-analysis as well? Yeah, Dr. Jacob, you can take the call. So.
This is the criterion which is actually influence the overall survival. So with that, we'll be forced to give. In which case, I don't see any subset of lung cancer which we don't give adjuvant therapy.
No, I think the stage 1A, I think 1B onwards, I think they say, one of the high risk criteria, they say you can sort of, give adjuvant. But in 1A with angioinvasion, I think, Vijay, what is your take?
I think we'll wait for some prospective data. This just suggested that 1A, it comes, there's high chances of relapse. We don't know if we give chemotherapy, whether that would benefit or not. It just says that it's a poor prognosis.
Somewhere down the line, there was some other publication that suggested that, you give and it's slightly better than the ones which
there was a publication which came in JAMA Oncology last year, which talked about if it is around more than 3 centimeters, in between 3 to 4 centimeter, with lymphatic invasion, with vascular, 2 of these criteria, and if the patient has undergone a sublobar resection, that paper of JAMA Oncology did show that in this patient, this was a SEER database analysis, that this was the patient who would probably benefit. But only individually for a vascular invasion, they also had not seen, and especially less than 3 centimeters, they didn't find any benefit.
So maybe with 1A and 2 or more of the factors, angiolymphatic and all, would you sort of be inclined to sort of consider?
I think that would be an individual patient discussion.
Dr. Arvind, I think some publications stressed on this thing that some poor prognostic features, like angioinvasion is one of them.
Right.
STAS, angioinvasion, lymphatic invasion, and the micropapillary pattern. And the visceral pleural invasion.
Visceral pleural involvement. Visceral pleural, of course, is a part of the TNM now.
Yes.
Somehow, I guess possibly the next TNM you may have a possible change incorporating angioinvasion, considering the prognostic significance that has been consistently shown.
Most relapses, even in early stage, are systemic.
Right.
So I think it's very important that we should start.
And maybe pathologists should start looking into it, as Durgatosh mentioned, into more deeply, whether it's arteria, vein, or intratumoral, extratumoral, all those aspects, I guess. I think as it is described in thyroid cancers, possibly this will also come more into the lung cancer domain as well. And this is something very interesting, chest X-ray versus CT chest. And Virendra, elegantly, he brought up the other aspects also, which I really enjoyed, Virendra. I think apart from the publication, you just sort of, surveyed the evidence, in the limited time, and I really appreciate. What will be our regular follow-up criteria? Maybe Priya, you can sort of, tell, are you inclined to change practice with this, considering that, there is no overall survival difference is not
actually,
there.
I second Virendra in that, because the last slide which he presented was one of, somewhere I think we are on the same page, that if you are able to catch an asymptomatic recurrence in a otherwise fit patient, we are able to give them a better chance for a salvage therapy or maybe early starting of chemotherapy plus minus targeted. So I would actually stay with a CT-based follow-up for now.
Right. Yeah.
I have a different take on this.
Right.
So I think we need, with the data that Virendra presented in terms of the early stage cancers having a 25% local recurrence rate, as in
10 to 15 he mentioned.
whoever record, 25% was low.
Oh, okay. Yeah, right. Okay, good.
Whereas in stage 3 and above, there was more systemic. 85% was systemic.
Correct.
So I think it's time to tailor our follow-ups. And if I had to pick and choose, I'd pick my early stage cancers with a CT because they have a longer life. The second primary rate increases. And the later cancers would still be an X-ray based follow-up because they are going to recur systemically. And there is no data as of now to say that instituting systemic therapy early before they become symptomatic adds to any survival advantage. So I think it's time for a tailored follow-up.
No, but they are changing, no? A lot of systemic therapies is being added, and I think the next 2.5 days will be sort of, spent on this only, adding more therapies. Yes.
The CT-based follow-up, we are likely to, detect more second primaries, lung, contralateral, ipsilateral.
That's what it showed, more recurrences, and Virendra showed asymptomatic recurrences and also more second primary cancers.
Do you think the results would have been different if the study was not a French study but was an Asian study? Knowing that the French, the mutation positive rates are less, the driver mutation rates are less. If it was an Asian study, you may have seen differences separate because there you would have the higher number of patients with mutation positive.
So maybe you would have given more systemic therapy for those patients. You would have gone the Adora way or something of that sort for these patients. No, the thing is, Virendra very elegantly pointed out, what is happening now is more amount of adjuvant therapies are being added. Dr. Jacob, you wanted to add something on this, since you've been largely silent in this. Dr. Jacob? So much of, I'm sure that 2.5 days of thing are there, but just for the favor of the panel, so much of adjuvant treatments are coming. So I guess what happens is the recurrences and all will be dependent on what is the intensity of your primary treatment. If you just stop short at surgery and not give some of these, then you expect some of the recurrences more to happen. So in an attempt to decrease the recurrences, I think that's where I guess a lot of pushes for, say, neoadjuvant and adjuvant therapies. And my feeling is the recurrences patterns will also be slightly lesser, essentially. That's what I feel. But interesting food for thought, as usual, which I'm not sure Japanese versus French, whether it would have made any differences. Priya, you wanted to say something. You just had the mic and then you put it down, no? Yeah, but what is the Shoaib, what is our regular follow-up of your patients? Do we do, because a lot of times, what I believe is a lot of people do PET CT also during the follow-up, and that's possibly what is done in the real world, A lot of centers and all they do. What is your take? How is your practice? And I just wanted that as well.
Being in a private center, if I don't advise a PET CT, they ask for it. Doctor, we want to do a PET CT. So regularly we have started doing PET for them, at least once in 6 months.
Right. Devani, how was your thing? No, I understand you have the luxury of being in a sort of, center.
We can call that luxury, but we still stick to chest X-ray and clinical follow-up.
CT?
We don't. We still do a chest
okay.
X-ray.
Oh, interesting.
And CT is reserved only if the X-ray shows an abnormality or if the patient has any symptoms.
Right. So you're giving less work to Amit and
No, that's not true.
Yeah, Priya, what is your take? So how frequently do you do,
So I am, as I said, I agree, I am a CT-based follow-up person.
CT.
But also, if it's in a private practice, just like what Sir said, if we don't ask for a PET CT, the patient will ask for it.
Right.
So normally what I do in my routine follow-up is 3 monthly X-ray. So it's X-ray, then 3 months CT, then X-ray, and then a PET. That's how it goes. So everyone is happy,
So,
me, patient, and the rest of me.
No, in fact, very good point. No, even we also do the same thing as well. Because at every time the patient comes, in lung, you don't know what to do. You just they use your steth and you supraclav, you palpate, and then So at least one chest X-ray, every 3 months, and then every alternate time you do a CT chest or something like that. Now you are assured, patient is also assured that their follow-up, something is being done for this patient. But as Shoaib said, some of our real-world practices, most of us tend to do most of them tend to do PET CT, not just because the evidence is there. Evidence, of course, is not there. Evidence suggests that, for majority of the cancers, in fact, they say that, minimal surveillance is actually reasonably good enough in terms of, but I must commend it. It's a good randomized control trial. I think today we can follow up and say, you need not do PET CTs, at least, in those.
You have to divert something from the discussion. Can I ask something, sir?
Yeah,
so
please.
In private practice, how many of the people who are working purely in private will actually go and do even EBUS or mediastinoscopy for every patient who has got N1 on PET and say he has got a 5 centimeter lesion in the lung? which is a borderline. How many of in private practice will do an EBUS oblique median cystoscopy? It's 1 lakh extra. So I think I concur with Dr. Durgadosh sir, who we discussed many years ago on this. No. So in an Indian scenario and private practice, it's not always the same as...
No, I agree. That's a different sort of I had also written one small editorial, and thanks to the CRST, they made me write one. So I think real world evidence in terms of, practice of, at least EBUS, I think most of them are trying to do, I guess, but mediastinoscopy, I agree that there may be a little short. Sure, we
usually do EBUS if for a small peripheral lesion, the nodes less than centimeter nodes, then we have the option of not doing anything, and large nodes, I think mediastinoscopy we are not doing nowadays for operable cases.
Yeah, there are many aspects in oncology, wherein the evidence and real world practices may be different for various reasons, and maybe PET CT is one thing, and maybe practice of mediastinoscopy to some extent. EBUS, of course, it depends on the access and availability. If it's there in your center, you would sort of be more inclined to do it. If it's there in a neighboring center, you possibly may do it alone. I think any final thoughts on this, and I think we are.
I think the practice in Asian countries versus American and European countries is different.
Right.
In Asian countries, most of the guidelines say that small, like N1 station node, if the N1 is positive versus N2 positive, they say if the N2, one single station node is positive, then it is okay to do straight surgery without doing any invasive medicinal staging. So,
no, I am aware of that.
Also does not differ.
Single node less than 3 centimeters. I've seen people knocking off, going for straight surgeries even in a single N2.
In fact, as like British Thoracic Society guidelines and the Japanese and the Korean guidelines, they say multi-station single zone involvement less than 3 centimeter nodes, surgery should still be the treatment of choice.
Right. Great. Yep. Okay. I think in the interest of time, I'd like to wind this panel. Thank you, panelists, for that wonderful opportunity, and thank you, audience. Thank you once again.